Welcome to Obesity Chronicles. My name is Robert Kushner. I'm a professor of medicine and medical education at Northwestern University Feinberg School of Medicine at Northwestern Medicine in Chicago, Illinois. Before we get started with today's podcast, I'd like to note that this program is intended for healthcare professionals. The information presented in this podcast is aligned with views and opinions of the speakers and is sponsored by Novo Nordisk. Some speakers have been compensated by Novo Nordisk for their participation in this program. This podcast is not to be used as medical advice and is intended for educational purposes only. It is not approved for continuing medical education credits. In today's podcast, we will be talking about adolescent obesity. Specifically, we will address the complex interplay between multiple factors that contribute to adolescent obesity, the increased risk of comorbidities that adolescents with obesity may face, the stigma and bias endured by adolescents with obesity, and recommendations and implementation of the American Academy of Pediatrics guideline for managing adolescents with obesity. I am pleased to be joined today by Drs. Edmund Wickham, also known as Trey, and Aaron Kelly. Trey and Aaron, would you please introduce yourselves to our audience?
Thanks, Bob. It is a pleasure to be here with the podcast today. I'm Trey Wickham, a professor of internal medicine and pediatrics at Virginia Commonwealth University and Children's Hospital of Richmond at VCU. I'm an endocrinologist who specializes in the care of youth and adults with obesity, and I co-direct our comprehensive pediatric obesity treatment and research center, which is called the Healthy Lifestyle Center.
Aaron?
Yeah, thanks, Bob. My name is Aaron Kelly. I am a professor of pediatrics, and I co-direct the Center for Pediatric Obesity Medicine at the University of Minnesota.
Thanks, Trey and Aaron. Well, let's get started by defining obesity. The World Health Organization defines obesity as an abnormal or excess fat accumulation that presents a risk to health. Aaron, let's get started with you. How does the American Academy of Pediatrics define adolescent obesity?
Just as you said, Bob, the American Academy of Pediatrics defines obesity as a chronic disease that results in altered anatomy, physiology, and metabolism, all of which adversely affect the physical and mental health trajectories of children and adolescents, similar to adults. However, the screening for obesity in children differs from adults. For adults, a BMI of 30 or higher categorizes an individual as having obesity. In contrast, for pediatric patients, BMI is adjusted for age and sex due to the physiological changes during growth. And so a BMI at or above the 85th percentile but below the 95th percentile for pediatric patients of the same age and sex is categorized as having overweight, whereas a BMI at or above the 95th percentile for pediatric patients of the same age and sex is categorized as having obesity. The U.S. Centers for Disease Control and Prevention, or CDC, and the American Academy of Pediatrics recommend using the 2020 CDC growth charts to monitor growth in children and adolescents ages 2 to 20 years, and the 2022 CDC extended BMI for age growth charts for children and adolescents with a very high BMI, defined as a BMI above the 97th percentile.
Well, clearly, the American Academy of Pediatrics defines obesity as a disease. Do patients and your caregivers understand that obesity is a disease?
Yeah, that's a great question, Bob. So when obesity is understood as a disease, it may unburden the patients and their families and caregivers from a lot of the stress associated with living with overweight or obesity. Society places a stigma on people who live with excess weight. But when you understand that much of someone's body weight is influenced by genetic predisposition and biological factors that are largely beyond the control of the individual, it can help disarm families from the outset so that they don't feel like it's their fault. And then healthcare professionals can consider a variety of treatment modalities that can offer patients a sense of hope when managing their weight.
I agree with Aaron that it's essential that we recognize adolescent obesity as a complex chronic disease. The American Medical Association recognizes obesity as a complex chronic disease that requires medical attention. However, frequently, it is mistakenly stigmatized as a consequence solely based on personal choices. We know increasingly more about the intricate pathways that regulate appetite and energy metabolism, and how in individuals with obesity, these pathways are altered. We also know that there are biologic and metabolic alterations that contribute to the comorbidities associated with excess weight. What's been exciting about these discoveries and increased understanding is that they have allowed us to begin to develop effective treatments by directly targeting some of the altered pathways that contribute to obesity.
Trey, could you talk to us about the various factors that contribute to obesity?
As we have emphasized, obesity is not simply a matter of eating too much, not exercising enough, or lack of willpower. Obesity results from a complex interplay between a myriad of factors, including environmental, behavioral, social, genetic, and epigenetic, as well as physiologic factors. Collectively, these factors contribute to alterations in anatomy, physiology, and metabolism, which can negatively impact the physical and mental well-being of adolescents.
Trey, could you tell us more about the environmental factors that you mentioned? I think it's particularly important to talk about this regarding adolescent obesity.
I agree. Many of the risk factors for obesity can be characterized as social drivers of health. Social drivers of health are the conditions or factors in the environment where people are born, live, learn, work, play, and age that affect a wide range of health, functional, and quality of life outcomes and risk. The social drivers of health domains include economic stability, education access and quality, healthcare access and quality, neighborhood and environment, as well as social and community context. Adverse environmental factors and social drivers of health can cause alteration in one's physiology, which may impact energy balance and weight regulation. Obesity tends to cluster in social groups as well as families.
Trey, it's interesting that you are using the word drivers as in social drivers of health versus social determinants of health, which is what a lot of us are used to hearing. Can you explain that a little bit more to me?
Yeah, they could be used interchangeably, and the American Academy of Pediatrics guideline talks about both. However, many experts propose that driver is a better term because determinant conveys a sense of being fixed and fully defined regarding health, whereas a driver is something that is fluid and not the sole determinant. Obesity does not affect all population groups equally. It's important for clinicians to understand and appreciate the role of these factors which are outside of the patient's or family's control, when understanding, evaluating, and treating adolescents with obesity.
Aaron, I want to shift our conversation to the underlying biology of the disease. Can you talk to us about the physiological mechanisms that modulate energy balance and weight regulation? I think these are important to review because those who may still believe that adolescent obesity is simply due to personal failures and or parenting failures, rather than recognizing it as disease with underlying pathophysiology.
Yeah, so the brain processes homeostatic and non-homeostatic signals to serve as the master regulator of appetite and eating behavior. It integrates input from the environment and hormone signals from the gastrointestinal tract, pancreas, and adipose tissue to generate emotional and cognitive impulses to control food intake. Body weight is regulated within these complex multifactorial circuits, and our body is programmed in such a way that if the target value of body weight has shifted, the body makes adaptations within these circuits to reach their higher weight. And these adaptations within the homeostatic system can have such a strong impact that conscious influence on food intake is no longer effectively possible. Thus, weight gain is much easier than maintaining weight loss.
So, Aaron and Trey, these are complex physiological mechanisms, and it can be hard for patients to understand this. I'm really interested. How do you both explain this to patients and their caregivers?
I think we're going to get to this later in the podcast, but just to mention now, before you have this conversation, I think it is really important that we pause to understand the importance of asking permission to talk about weight with our patients. So, as Aaron talked about already, many of our patients have experienced substantial bias and stigma, and unfortunately, that can often be from the healthcare team and healthcare professionals. So I think a quick pause with a patient to say, it sounds like you have some concerns about your weight. Can we discuss that more is really important, even before we start launching into a discussion about obesity with adolescents. In regard to the patient's and family's understanding of the underlying pathophysiologic mechanism of obesity, it's definitely something that takes time to help patients understand. But really, I would say it's worth it. As Aaron already shared, so many of our patients and families are coming in thinking that this health condition is solely the result of their poor choices. So it's really important for us to unpack the complex physiology of obesity in a way that's accessible for patients and their families. Understanding how weight can be influenced by so much more than just personal behaviors, and highlighting the roles of genetics as well as hormones and other pathways in our body that contribute to appetite and the way that our bodies handle energy will benefit patients and families immensely.
Trey, one of the points you mentioned was using non-stigmatizing language, asking permission to talk about weight, etc. I think the language that we use to address the disease of obesity is very important. Many people with obesity face weight bias and stigma, and adolescents, unfortunately, are no exception, and a lot of the times from their own clinicians. Aaron, can you talk more about this?
Yeah, I know we'll say this a bunch of times today, but we need to keep saying it. Obesity is a disease and should be discussed as such. Weight-related discussions can be uncomfortable for clinicians who want to avoid stigmatizing adolescents because of their shape or size. However, avoiding this discussion may cause delays or barriers to patients receiving appropriate care. These things are important to keep in mind because one study reported that 24% of 427 parents surveyed said they would avoid future appointments for their children due to perceived stigmatization by their child's doctor. Understanding weight stigma and bias and learning how to reduce it in the clinical setting sets the stage for productive discussions and improved relationships between families and pediatric healthcare professionals. While the specific wording and how one interacts with their patients should be personalized to the individual, some common consideration should always be at the forefront of your mind when talking with patients. For example, the word obesity should be separated from the individual, as in, never assume or imply that the identity of the adolescent is their weight. The CDC, the Obesity Action Coalition, and the American Academy of Pediatrics all encourage the use of person-first language when discussing obesity and other chronic diseases. So, for example, say adolescents with obesity rather than obese adolescents. Healthcare professionals are encouraged to discuss body weight in neutral terms. This can be a way to frame the discussion around the health concerns and complications that come from obesity, and not just the weight. Words like fat and normal weight should be replaced with weight and healthy weight. Another example of non-stigmatizing language when managing patients with obesity is, instead of saying unhealthy foods and exercise, you could say less healthy foods and physical activity. And of course, this goes beyond language. Additional actions that help reduce weight stigma include having appropriately sized office furniture, using appropriate capacity medical equipment, and ensuring that aesthetic and/or instructional images posted in the offices are inclusive. So as we said earlier, we know that obesity is a disease resulting from physiological, environmental, and genetic factors, and not from bad decisions or moral failings. And it is our imperative to not further stigmatize patients and their caregivers.
Well said, Aaron, and I agree completely. We talk about the same issues of people-first language when we address adults. Trey, do you want to add something else about this?
Again, I wholeheartedly agree with everything that Aaron just shared. And I would say, among many of the things that we talked about, that helping clinicians adopt and use an approach that's non-stigmatizing and really empowers and supports their patient is essential. It's not just about the clinician being seen as kind or having a good bedside manner. We know that there are adverse health outcomes when patients experience weight bias and stigma. As Aaron said, they're less likely to come back to see their clinician. And on top of that, they may be more likely to engage in unhealthy eating patterns, including loss of control and emotional eating. The stigma experience has a direct health impact on our patients.
Shifting gears a bit here, there are other physiological changes that occur in obesity that put patients with obesity at greater risk for other complications and comorbidities. Aaron, can you speak to us about that?
Simply put, when fat cells can no longer expand to store excess triglycerides, they become hypoxic and create a pro-inflammatory environment, which has a far-reaching impact on other organ systems. So eventually, once adipose cells are no longer able to expand, they become fibrotic, rendering them unable to store additional triglycerides. And then other organs, such as the liver, the muscle, pancreas, end up storing them, leading to increased risk of other diseases. However, it is important to note that the storage capacity and metabolic function of adipose tissue depends on its anatomical location. For example, adipose tissue accumulation in the hips and flanks does not have an adverse effect and may even be protective against metabolic syndrome. So many of our adolescent patients with obesity already have some form of insulin resistance, type 2 diabetes, or prediabetes. In addition, many adolescent patients with obesity we see also have hypertension, dyslipidemia, musculoskeletal problems like fractures, mental health concerns, and this includes anxiety, depression, and disordered eating habits, and metabolic dysfunction associated steatotic liver disease, to name just a few. And we know that this places them at higher lifetime risk of future chronic health conditions. In addition, the long-term prognosis for adolescents living with obesity includes increased risk for many other obesity-related health conditions, including those that can manifest into adulthood. This includes coronary artery disease, some types of cancer, infertility, osteoarthritis, and type 2 diabetes. These health conditions all have significant morbidity in childhood and across a patient's lifespan. Recently, the American Academy of Pediatrics pointed out that the risk for some of these related comorbidities and complications in our young patients with obesity may be higher, with greater severity of obesity and/or progression than commonly or previously thought.
I agree with everything that Aaron has said. The immediate and longer-term health impacts of obesity during adolescence can't be overstated.
Trey, do you think this concept is understood by adolescent patients regarding their increased risk? And what about their caregivers? Do they understand the serious problems that obesity can cause in adolescent bodies?
In my clinical practice, I find that often the reasons that a parent is bringing an adolescent for evaluation is because some of these health concerns. They've had a family member or other people they know who have been impacted by obesity-related health conditions. Many times I see parents or caregivers who themselves have been impacted by type 2 diabetes, and they want to prevent these complications or conditions in their child. Another key point to take note of is that many of these conditions we just mentioned don't necessarily present with symptoms right away. And therefore, we need to make sure that patients with obesity are being appropriately screened for some of these other health conditions so that we can detect and treat them early. Lastly, one of the things that's really important as we're thinking about treating adolescent patients is understanding that the adolescent's motivations for seeking treatment for obesity might be really different from those of the parent. Although they may have some of the same concerns about these health conditions, their concerns and part of why they're interested in treatment might be very different.
Yeah, to that point, Trey, the cross-sectional survey-based Global Action Teen Study aimed to identify perceptions, attitudes, behaviors, and barriers to effective obesity care among adolescents with obesity, their caregivers, and healthcare professionals. Interestingly, adolescents cited their primary motivation for seeking clinical obesity care as being more fit or in better shape, with the goal of feeling more confident and better about themselves.
Yeah, that's a good point. So we've discussed the health risks and staging of adolescent obesity, but Trey, how should healthcare professionals be screening their adolescent patients for obesity and related health conditions?
So, Bob, an evaluation of an adolescent with obesity should take everything that we've discussed about the causes of obesity and social drivers of health into consideration. The evaluation should include a complete medical, medication, family, and social history. Family history should include a history of obesity and obesity-related conditions, including type 2 diabetes and premature death due to cardiovascular disease or stroke. The social history should help elucidate the impact of social drivers of health we discussed earlier. As part of this evaluation, healthcare professionals should include an assessment of the patient's obesity-related health conditions and lifestyle factors, environmental and socioeconomic factors, a physical examination, and psychosocial assessments that include screening for depression, anxiety, and dysregulated patterns of eating. Symptoms of underlying genetic causes of obesity, although relatively rare, should be screened for and assessed during the history and exam. Healthcare professionals play a vital role in assessing and treating obesity and other related conditions in adolescence. They should recognize and treat obesity as a chronic disease. Clinicians should feel confident and be actively screening for obesity, its associated health conditions, and either providing or connecting patients with the resources necessary to manage their condition. The comorbid conditions that adolescents with obesity should be carefully screened for include hypertension, glucose intolerance or diabetes, dyslipidemia, metabolic dysfunction-associated steatotic liver disease, and obstructive sleep apnea when appropriate. Many of the obesity-related conditions we discussed earlier are well-established cardiovascular and metabolic risk factors and may already be present in youth with obesity.
Trey, how much pushback do you actually get from the caregiver and or adolescent regarding this workup?
Bob, as I mentioned, the adolescent and their parent or caregiver often have different goals for seeking treatment. And it's often more the parent or caregiver who is most interested in this screening, in my experience. Which is not to say that adolescents don't also have concerns about these conditions. With my patients, I discuss what we want to screen for and why that's important. Then we collectively come up with a decision for next steps that meets their goals, values, and preferences.
Global rates of adult obesity have doubled since 1990, and the numbers for adolescent obesity are concerning. In the same time frame from 1990 to today, worldwide adolescent obesity has quadrupled. I think it's clear that we must take action against adolescent obesity. Trey, what does the American Academy of Pediatrics recommend?
Bob, the American Academy of Pediatrics, in its clinical practice guidelines, highlights a lot of the things that we've already been talking about. Specifically, they emphasize that obesity is a chronic disease and, as such, warrants ongoing assessment and treatment in the context of the medical home. As an aside, the medical home is a venue where pediatric physicians known to the adolescent and family deliver or direct continuous and comprehensive primary medical care. All care should use an approach that minimizes stigma and carefully considers the factors that are contributing to the healthcare needs of that specific patient and their family or caregiver. That being said, the treatment guideline from the American Academy of Pediatrics includes evaluating patients for obesity-related medical and psychological comorbidities and identifying and addressing social drivers of health, as we already discussed. The guideline also recommends using motivational interviewing, which is a patient counseling technique designed to better support healthcare behavior change that addresses nutrition and physical activity and uses evidence-based targets for weight reduction and health promotion. Clinicians should identify and set treatment goals in collaboration with the patient that go beyond BMI stabilization and include goals for improving or resolving comorbidities, quality of life, and self-image, and other goals related to holistic care. Once treatment goals are initially set, the guideline recommends providing intensive, longitudinal treatment and continuing to tailor treatment to the ongoing and changing needs of the individual patient and the family in the context of their community and integrating weight management strategies across appropriate disciplines. These can include intensive health behavior and lifestyle treatment and/or pharmacotherapy or surgery if indicated. An overarching goal of obesity treatment in adolescents is to improve their overall health and quality of life, and to prevent or manage obesity-associated health conditions in adolescents with obesity.
Well, both Trey and Aaron, thank you for this really informative and nuanced discussion of the care of adolescents with obesity. Incredibly important insights you shared with us. So with this guidance in mind and considering the topics we've covered today, what is your call to action to clinicians? Aaron, I'll start with you.
I would say the starting point is entering these conversations with an attitude of humility, empathy, and compassion to help prepare parents and adolescents to be willing to engage in these important conversations. Working to talk to parents and adolescents describing obesity as a disease in the frame that it's not your fault, we're here to help, and we have tools that can help you if you want to work with us on these things. I think we've come a long way in just the last 5 years in this field, where before there was a sense of hopelessness on the part of clinicians and more importantly on the part of parents and adolescents. And that's changing, and it's changing fast because the science has evolved and we have treatment options that work. Now there's a sense of forward momentum that we can help get these kids on a healthy track. Momentum that if we get it right early on, we may get it right for life. We're in a new era where we can make a really big difference.
Trey?
I agree. It underscores so many things Aaron already shared. We've heard over and over again that's important for healthcare professionals to not only understand, but also communicate to patients that obesity is a complex chronic disease. One of the challenges, and actually skills necessary for healthcare professionals who care for adolescents, is framing this discussion in a way that makes sense to our patients based on their developmental stage. I think another thing that warrants repeating is the importance of asking permission to talk about weight before we launch into this evaluation and discussion, and really respecting what our patients and their parents say. It can be challenging when a parent is really concerned about their adolescent's weight, and maybe the adolescent isn't. Those are definitely tricky situations where I think we need to respect both parties and move forward in a way that recognizes both parties' concerns. And lastly, as we continue to expand our understanding of the pathways that contribute to obesity, we are also expanding the availability of effective treatments for eligible adolescents, in addition to lifestyle modification, and now includes pharmacotherapy and bariatric or weight loss surgery. I would encourage my colleagues to continue to gain the skills and confidence required to collaboratively develop individualized, effective treatment plans for their patients with obesity. This includes gaining experience in prescribing and monitoring pharmacotherapy, as well as identifying patients who may benefit from bariatric surgery. It is also vital that clinicians recognize what resources are available in their communities, including programs that may be available to provide a higher level of care for our adolescents with obesity.
Thank you both so much for a great discussion. This concludes this episode of Building Bridges, Fostering Positive Dialogue about Adolescent Obesity. Please join us for the next episode of Obesity Chronicles, A Novel Perspective. For more information, please visit rethinkobesity.com.